Thank you, Dr. Sharon, and thank you to AIOC for the opportunity. So this would be another aspect of trauma. Sometimes patient is also in plight, and we are also in plight dealing with traumatic optic neuropathy. But let us take a look at what are the management options and a few cases that I have put up. So coming to trauma, like everyone has said, so the insult to the optic nerve, unfortunately, sometimes because the optic nerve doesn't have a capacity to regenerate, ends up being a permanent vision loss. But depending on the type of trauma, it can be there can be a variability in the vision loss. So the site of injury can be either in the optic nerve head, in the intraorbital segment, in the intracanalicular segment, or even in the intracranial portion of the optic nerve. So the mode of the injury can be a direct, where there is a traumatic optic nerve avulsion, that is the fibers are lost, or an indirect optic nerve, that is via the Coop and contra-Coop mechanism, where there is a transmission of the forces from a distant site. So as we all know, there is an injury to the optic nerve, then there is there's a swelling, and this sets up a compartment syndrome, which further compromises the blood supply to the optic nerve, leading to apoptotic cell death. So the diagnosis of traumatic optic nerve, optic neuropathy, we do need to rule out other causes of optic neuropathy. Many of our patients are diabetic, hypertensive. They could be having a pre-existing ischemic optic neuropathy with a coexisting history of trauma. And we need essential neuroimaging in the form of CT or MRI. We need a proper clinical assessment, and we need to also look for associated intracranial traumas, because it may not be important to manage the traumatic optic neuropathy when the patient is having an intracranial bleed. So at this point, we need to rule out intracranial trauma and refer the patient to the neurologist or the neurosurgeon, and you need to manage accordingly with the neurology team. Okay. So coming to the first case, this is a 22-year-old male who had a tire blast injury, who was not wearing any protective gear on the face, and he had immediate loss of vision post-trauma. So the right eye was no perception of light, left eye was 6/6. So here, this is the right eye where he had a shearing right from the mid portion of the intraorbital to the intracranial portion of the optic nerve. So all we can see is the left optic nerve is normal, and the right optic nerve, there is increased cupping and pallor of the disc. So in this case, this patient was seen in the army, and he didn't have immediate access to medical facilities. So nothing much could be done about the optic trauma per se, except he received a dose of IV methylprednisolone, but of course he did receive it in the appropriate period, but didn't have any improvement. So the next case is a 28-year-old male who was just a bystander on the road, who was hit by a heavy motor vehicle. So the mechanism of injury also plays a very important role in most of these patients. So unfortunately, this patient had a bad hit to both his eyes. The right eye was a thusical eye with a globe rupture and a vitreous hemorrhage. The left eye, he developed a traumatic retinal detachment with a membrane on the optic nerve with an avulsion. So this basically is the left eye showing a lot of glial tissue proliferation with the optic nerve head avulsion, and both eyes he had no vision. But at this time it may feel like in vain because the patients keep asking what else can be done. But I think as a medical personnel, we are also entitled to say when there is treatment and when there is no treatment, because giving treatment might do more harm than help the patient, because putting this patient on a dose of high dose steroids might lead to worsening of or creating an endophthalmitis or a panophthalmitis. So the third case is basically, I've just put it up to see that not all optic nerve injuries or not all nerve injuries might be a traumatic optic neuropathy if there is a relative afferent pupillary defect. So this patient was a 25-year-old male who had a two-wheeler on two-wheeler collision. He had traumatic brain injury with multiple facial fractures which had been repaired elsewhere. And his vision in the right eye was 6/18, left eye was 6/6. The color vision was in the right eye 12 plates, the left eye was 21 plates. So many patients who come may not have a clear-cut afferent pupillary defect. Most of them have an coexisting traumatic mydriasis or an associated third nerve palsy with ophthalmoplegia. So we need to do a reverse RAPD to check if there is an afferent pupillary defect or not. So in this patient, obviously the afferent pupillary defect was there, but it was not coherent because in a traumatic optic neuropathy, you get a full-blown afferent pupillary defect when they have a loss of vision. So he had a partial ophthalmoplegia. So what he actually had was a submacular bleed. So this was referred to the retina and he underwent pneumatic retinopexy. So not all afferent pupillary defects, we have to correlate with vision, color vision and the rest of the retinal findings and make sure that it is only a traumatic optic neuropathy that we are dealing with. And the next patient is, I just want to show this. So basically he had loss of vision in both his eyes. As you can see that the left eye has a bit of anisocoria compared to the right eye. The right eye is reacting but sluggish. The left eye, you can see the afferent defect very clearly. So he was sedated and he had a history of assault. And he had multiple intracranial hemorrhages and he underwent decompression craniotomy. So the right eye vision initially on assessment was 660 and the left eye was a no PLI. Both eyes, of course, he has an advanced optic atrophy. But this patient was given only conservative management, and as you can know, there is some amount of natural recovery also that happens in traumatic optic neuropathy, and he improved naturally to 615. So the importance is to look for any segment of a bony fracture impinging on the optic canal, to look for any intracranial pathology like bleeds, and always do visual field assessment in the other eye because the other eye might have a hemianopic defect because of an intracranial bleed. So there are many indirect mechanisms of indirect optic neuropathy. So if the angle is between 0 and 45 degrees, the damage is more severe than if it is between 90 and 180 degrees. So it is important to know what type of impact it is, and the most common segment is the intercanalicular segment where there's tugging between the brain and the optic nerve. So this is one human model that has been studied which showed that at the angle of 0 and 45 degrees was the maximum impact of traumatic optic neuropathy. So the treatment can be observation, high-dose corticosteroids, erythropoietin, surgical or experimental things. There's still no conclusive or reliable evidence on the management of optic neuropathy. So there are many studies with high-dose steroids, but these are controversial. Sometimes they say it's best left alone, but if there is intrasegmental edema, we can go ahead and give the steroids. Erythropoietin has been tried. There are a few pilot studies where they've showed that there is some amount of hypoxia and reduction in apoptosis with erythropoietin, 3 days of 20,000 international units of erythropoietin. Optic nerve decompression, definitely if it is within the first week of optic neuropathy, preferably in the first 3 days, we refer to a neurosurgeon to do the optic canal decompression and optic nerve sheath fenestration. And there are a lot of experimental evidence on multiple molecules that have been investigated for optic neuropathy, like glutamate antagonists, anti-inflammatory cells, stem cells. Hypothermia is something that people are trying out, and certain lipids, because the optic nerve is made of a lot of lipids, and implantation of mitochondria. So thank you so much.
Thank you, Dr. Anusha. I know it was a very large topic to cover, but so often these are things which confuse us as to what we